Dear friends, welcome to you all. Today I am going to talk to you on a subject which is very fascinating, very interesting, and which many of us are not very familiar with in investigating and treating. That is vertigo. Vertigo is a very common problem, as you all know, and we need to have a very clear understanding of how to evaluate such patients and refer them for special tests and put them on appropriate treatment. Okay? All of us are very familiar with our 5 special senses, but we are not familiar with our 6th special sense, the equilibrium, the sense of balance. This is often referred to as the 6th sense. Why is it so, and how is it maintained? How is it disturbed? This is the crux of today's lecture. This is a schematic representation of our ear and the hearing apparatus. The external auditory canal, the drum membrane, the middle ear, the 3 ossicles, incus, malleus and stapes, the foot plate of the stapes, the oval window, and then the 2.5 turns of the cochlea, the hearing organ, the cochlear nerve, the 3 semicircular canals, the vestibule, the vestibular nerve, together the vestibular cochlear nerve going towards the brainstem. This is an animated representation of our hearing mechanism, how the sound waves through the external auditory canal come and impinge on the drum membrane, transmitted via the 3 ossicles to the foot plate of the stapes on the oval window, and from the oval window to the cochlea, and from the cochlea to the cochlear nerve. Our inner ear is called the labyrinth. In the labyrinth we have 2 separate entities. One entity which takes care of the hearing, that is the cochlea, the cochlear nerve and the hearing mechanism. The other entity is the vestibular apparatus. Vestibular apparatus is concerned with the balance and then position sense and related to our equilibrium. This vestibular apparatus, as you can see here, is composed of 3 semicircular canals, the vestibule and the vestibular nerve. The vestibular nerve joins the cochlear nerve and forms the vestibulo-cochlear nerve, otherwise known as the 8th nerve, which goes in close proximity to the 7th nerve. Let's have a closer look at the vestibular apparatus. It has got a bulbous part which is called the vestibule and the semicircular canals or semicircular tubes here, as we can see, 3 in number, the lateral one, the posterior one and the superior one. These semicircular canals are arranged at right angles to one another, and they are important in perceiving the angular acceleration and angular velocity of our head in relation to the body and the environment. These semicircular canals end up into the bulbous part of the vestibular apparatus. The bulbous part of the vestibular apparatus contains the utricle and the saccule. Together they are known as the otolithic organ. How is our sense of equilibrium maintained? How is our balance maintained? It is by the vestibular apparatus. This has got 2 important components, the otolithic apparatus and the semicircular canals. The otolithic apparatus is again made up of utricle and the saccule, and these in turn contain small, tiny calcium carbonate stone-like structures. These calcium carbonate stones are dispersed on a membrane called cupola. Whenever there is a movement of the cupola, there will be a movement of the otoconia, and these otoconia, because of their movement, when they are attached to the hairs of the hair cells, the hairs bend, and that bending movement is understood by the hair cells, and those signals are transduced into the brain, and any linear movement of the head is interpreted by the CNS. Then of course we have got the 3 semicircular canals. Normally the semicircular canals do not contain any otoliths or the stone-like structures. They contain a fluid called endolymph, and then there are cilia inside. These cilia convey the information about angular movement of the head, and all the cilia, the movement of the cilia in the endolymph is transmitted to another big cilium called the kinocilium, which in turn transduces the signals and then makes the brain understand what is the angular moment of the head in relation to the body. Of course, all this information from the vestibular apparatus is connected very closely to the eyes, oculomotor muscles and the spinal muscles through the pathways called the vestibulo-ocular reflex and then the vestibulo-spinal reflexes. For a comprehensive integration of the information from the vestibular apparatus, the small tiny computers in our ear about the balance, this vestibular apparatus has to be connected to various parts of the brain, mainly to the oculomotor muscles through the VOR, vestibulo-ocular reflex, to the cerebellum. This is the vestibulo-cerebellar connection. To the brainstem through the vestibulo-bulbar tracts. To the spinal muscles through the vestibulo-spinal tracts or the vestibulo-spinal reflex. And of course, vestibulo-cortical connections will inform the cortex about the position of the head, the movement of the head, linear movement of the head, angular velocity, angular movement, position of the head in relation to the body and the environment. All this information is synthesized and appropriate motor responses are made by the central nervous system to adjust the posture and see that our body and head are kept in equilibrium. Our equilibrium is maintained by three systems. Basically, the most important system is the vestibular apparatus. In addition, the visual stimuli are also transmitted onto the brain to keep the balance. The third thing are the sensory information from the joints, from the bones, from the skeletal muscles. So, the visual pathways, the vestibular pathways and the proprioceptive sensory pathways leading onto the brain tell the brain about the spatial orientation of the body and the head, and brain in turn, the CNS in turn sends impulses, motor orders to keep our balance in such a way that we are not thrown off balance, such a way we don't have any unsteadiness or vertigo. This is how our balance is kept by three important mechanisms. So a disturbance of any one of these mechanisms, either the vestibular or the visual or the sensory inputs, can lead to disequilibrium or vertigo or imbalance. So let us look at the different disorders which cause vertigo. If a patient comes with unsteadiness or lightheadedness and dizziness, it could be syncope, it could be vertigo, it could be gait ataxia. We need to make this basic differentiation. First of all, I will deal with vertigo in this presentation. Then in the end, I will tell you about the syncope and ataxia in a brief way. The symptoms of vertigo are many. Majority of the patients say that they feel the lightheadedness. They feel that they are falling onto the ground. They feel that they are dizzy. This word dizziness is a subjective term and it is usually meant as an equivalent of vertigo all over the world. We use the term as giddiness whenever we want to say that it is dizziness. Dizziness and giddiness are almost interchangeable. Sensation of movement of the body in relation to the head, sensation of spinning, sensation of the person revolving are also complained of. Swaying of the person to one or other side or forward or backward, or unsteadiness while walking, or as though the patient is pushed to the side are also common descriptions. About 10% of the adults above 55 have a problem of the vestibular apparatus. They have vertigo. Mild uneasiness to severe balance problems can be presenting. Please remember that the severity of the vertigo does not really always indicate the severity of the disease or the seriousness of the disease. Mild balance disorders may be due to very serious intracranial problems. Please take these symptoms of vertigo, unsteadiness, dizziness, giddiness, whatever the patient says, very seriously and try to really evaluate whether it is important for the patient to get a full workup and see whether any diagnosis can be obtained. What is physiological vertigo? It is a mismatch of the three systems of balance: the vision, the vestibular apparatus, and the proprioceptive impulses. There is a mismatch in them that results in physiological vertigo. As it happens in seasickness, as it happens in motion sickness, as it happens on merry-go-rounds, giant wheel rides, etc. Unusual positions of the head and neck, like painting a ceiling, or when we try to look at the bottom of the hill from the top of the hill from great heights, when we view motion pictures which move at a rapid speed, we do experience vertigo, and such vertigo is also physiological. There is also what is called the space sickness due to zero gravity environment there, that also produces physiological vertigo. Optical illusions that occur due to rapidly changing scenes in front of the eyes can produce physiological vertigo. But remember, lightheadedness is non-vertigo. Lightheadedness could be pre-syncope. It could be the beginning of the syncopal stage of syncopal attack, and after the pre-syncope, patient experiences the fall or the rear. The causes of vertigo can be broadly classified like this: otological causes, neurological causes, general medical diseases which produce vertigo, and psychological causes which produce vertigo. By far, otological causes are responsible for about half of the cases of vertigo. The remaining three, neurologic, general medical, and psychological, share about one-third of the remaining 50%. So, 50% of the cases of vertigo are due to the vestibular apparatus problem or the otological causes. The remaining 50% may be neurologic, may be general medical diseases, may be psychological. Let us look at the details of this classification. Otologic causes of vertigo can be further classified as asymmetric, symmetric, and cross-coupling. In asymmetric, we have one ear is normal, the other vestibular apparatus is abnormal or defective. Causes are vestibular neuronitis, labyrinthitis, fistula, Meniere's disease, and so on. Whenever there is a bilateral dysfunction of the vestibular apparatus, then that is called as symmetric, and this is usually caused by ototoxic drugs like gentamicin, kanamycin, other aminoglycosides, diuretics like Lasix, quinine, anti-cancer drugs, and so on. Sometimes vestibular neuronitis, if it affects both the sides, or labyrinthitis occurs in both the ears, that can also be resulting in bilateral loss, and that is symmetric. There is another variety called the cross-coupling, where you have one vestibular apparatus is functioning more, the other vestibular apparatus is functioning less. This is what is called cross-coupling or benign paroxysmal positional vertigo. This is by far the commonest form of otologic vertigo, BPPV, benign paroxysmal positional vertigo. The other one is, of course, the fistula and the superior canal dehiscence also can be cross-coupling. Look at the air-filled middle ear and the fluid-filled inner ear. If there is a communication between these two through an abnormal opening, that is called the fistula. An opening in the round window allows the perilymph of the inner ear to leak out